So one of your colleagues provided this for you all to enjoy. I thought that was quite good. Yeah. So, pathology is infiltrated everywhere. Pretty good, huh? So now that is fair game for the exam. It's been formally incorporated in the lecture. So, okay. What has holes but still holds water? What has holes but still holds water? A sponge. Very well done. What type of clothing do clouds wear? Reindeer. Or if you're a child, you would say thunderwear. Because that's funny. All right. I mean, you guys remember when underwear was a funny word to say? I mean, come on. It's still funny. Look at you. You're laughing. Underwear. All right. What do you call an alligator in a vest? An alligator in a vest. What's that? An investigator. Very good. All right. So this image is a special treat for us this afternoon. Excuse me. I bet you guys appreciate that. That was a fun surprise to see. You're all creativity, or somebody's creativity. All right, let's talk briefly about the exams. The exams on Monday. SI sessions are listed here. We've got a review that's going to be posted later today after lecture. Thanks to Ryan. I think that's a great way to augment your studying. So the key word there is what? Augment. Right? That doesn't mean replace or only study that. Or, oh, sweet, I didn't have to do anything until now. Right? I would say maybe use the review as a guide, a tool to say, is there anything on here that I have no idea what it means? That should be a red flag for you. Number one. Number two is maybe use the study tool or guide to guide you. So look at it initially and maybe evaluate what is your weekend going to look like. Okay? So exam 2 is kind of critical. We only have 2 exams remaining, and so this is, a big component of the remaining points. And so if those of you that are calculating, and a lot of you have been in my office, the game on Monday, meaning the exam on Monday, is kind of an important one to be prepared for. So I would make sure you're allocating enough time on the weekend. And I told one of your colleagues today, I'm just being honest, there's no shortcut to study. There's no substitution for time with the material. So I know you guys are ridiculously busy, I get it. But you might have to prioritize a little bit between now and Monday if you're trying to go after a certain score. Okay? There shouldn't be any surprises. It's a very similar format. I will say this piece of good news. The averages on the second exam tend to be a little higher than the averages on the first. I don't curve it down because of that. I'm not going to penalize the class because you guys do better. And then even better news, exam 3 tends to be the highest averages. So they slowly increase over time. It's foundational. I think the class builds on itself. So if you understand some of these key concepts, they plug into other concepts. There's a lot of comprehensive stuff that we talk about, that we point back to the first unit. You've probably already seen that. And for the most part, because the way that we organize this class, most of you aren't struggling with, like when I ask a question about last unit as it relates to new material, you're tracking with me. There's not like one person or crickets in the audience. You guys are actually answering the questions I'm proposing that are review style questions. So you're retaining this information. So we're kind of telling a pathology story for the whole semester, and you guys are remembering what chapter 1 and chapter 2, where we kind of introduce the key characters in this novel, you don't forget those things. I mean, some of those key characters are like inflammation, right? We'll have some images on the screen like before. You have the full class period. What's that, an hour and 15? I will shout out kind of how much time you have left. And if you have questions, please raise your hand, and either Ryan or I, and you can say, no, I need Ryan, he's not helpful at all, Dr. Keller. That's fine. So if you want to trade off because I'm not as clear, or vice versa, you won't hurt our feelings. It's fine. Okay, we're here actually on test day to kind of serve you guys, answer your questions. Anything else before we finish up the last little content before we've got to go on? Okay, 1 second. I apologize, but my daughter is calling me. Let me grab this. I apologize. Yeah, no, everything's fine. It's not even an emergency. But my wife and my kids, those are the ones that I will look at and say, all right, I apologize. So those are one of those emergency situations. Could be. She's the one that had the concussion. State finals are Friday and Saturday. She just got cleared. I bought her this like concussion headband. So we're like, oh, no, I'm dead serious. I like researched it. You could imagine. It's pretty good. There's some good products out there. So, and it doesn't look that bad. I mean, it's only like this big. It's got all these bumpers to keep people away. I mean, she'll be able to dribble down the field without anybody touching her. It's going to be amazing. I think it's illegal, but it's pretty safe. All right. So, sorry about the little interruption. We're going to talk about thyroid glands. We're going sequentially in order of kind of some key organs. And the thyroid is up next. Okay, where is the thyroid? Where's that gland sit? Right, basically at the neck. Okay, it sits in the throat neck region. It's a key structure for metabolism, and like we talked about, it actually happens to be an area that commonly has issues associated with adenomas or lesions of the thyroid. So I've got a close friend and 2 family members that have had thyroid issues. One family members, no, 1 family member and 1 close friend had the thyroid completely removed to be careful. And of course now the thyroid doesn't make any hormone. The thyroid gland, when it comes to cancer, tends to be an organ where we can battle cancer quite effectively. And one of the reasons for that is the thyroid utilizes or needs or uptakes, metabolizes iodine. And it's the only tissue in the body that utilizes iodine. So the way that we can specifically target chemotherapy to the thyroid is we can radio label iodine. So you can radioactively target iodine and put it in the body, and only the thyroid will take it up. And so you kill the thyroid, but you don't destroy any other tissues in the body. But you still destroy the entire thyroid. Okay. So I had a close friend, and this little anecdotal story for those of you that are going to be physicians or PAs or nurses. This is kind of an example of how not to do it. So my good friend was diagnosed with thyroid cancer. It is a long process, super nervous, he had biopsies and all this kind of stuff. Finally, fast forwarding over weeks and months of diagnostic energy, a lot of stress for the family. He's got 3 kids. And they finally say, we're going to remove the thyroid. And he's like, oh, okay. And he said, you know what? Don't worry about it. If you're going to get cancer, this is the kind of cancer to get. And he was like, was that supposed to be like a pep talk positive? And he's like, oh yeah, well, a lot of other cancers are very, very dangerous, and you'll die from it. But your cancer's fine. Don't worry about it. He's like, okay, I'm still worried about it. So what the physician was trying to explain is the outcomes in the prognosis for thyroid cancer is actually really good, very, very favorable. So that's probably what you should have led with. Okay, versus if you're gonna get cancer, this is the one to get. Like, as the C word is not a word that we like to hear. All of us are sensitized to cancer, right? To the word cancer. So, all right, so let's talk about the thyroid. Not a family member, okay? But very, very common. And hyperthyroidism, or thyroid toxicosis, is what this young individual is wrestling with. So this is July 7th of 2008. This particular individual has severe thyroid toxicosis. So now what ends up happening is they're hyperthyroid. The thyroid is overactive, so there's a lesion on the thyroid that makes the thyroid enlarge and actually produces functional hormone, thyroid hormone. And the thyroid hormone that's being produced, whether it's T3 or T4, could be either, has an influence over metabolism. So metabolism goes up. So now this individual is got elevated metabolic processes and can't keep weight on. It burns so many calories all the time, even while he's sleeping. And in this particular situation, with what we would call hyperthyroidism, this patient had a nodule, but another option is they could have had Graves' disease. Do you guys remember what Graves' disease? So there's two potential causes for hyperthyroidism that we're talking about here. This person had a nodule, like an adenoma, and so the lesion is active. The other option is Graves' disease. Graves' disease was a type 2 hypersensitivity. Type 2 hypersensitivity, we would make autoantibodies towards that stimulate what thyroid stimulating hormone typically does. And so now it turns on, it acts like thyroid stimulating hormone, and turns on T3, T4 production. Or a third option is the patient could have what's called a goiter, where there's a nodule that's there. It's not an adenoma, but there's a swelling of a particular portion of the thyroid gland, and it becomes overactive. Okay, so three possibilities for hypothyroidism. This patient had a little adenoma that was causing overactivity of the thyroid. And so that's the primary ways. Now, secondarily, you can have sort of a side effect where you've got hyperthyroidism, where you can have oversecretion of TSH coming from the pituitary gland. So the tumor could be in the anterior pituitary, making too much TSH, and now the thyroid down low is overactive. And that would be what we call a secondary hyperthyroidism. So we got 4 ways that you could result in this situation with this patient. A functional adenoma, okay? A patient that has Graves' disease, a type 2 hypersensitivity, which we talked about in the last unit. A patient who has a goiter, where we've got an enlarged nodule on the thyroid gland, and it's overactive. It's not cancer or a lesion that is cancerous, it's just an overactive tissue collection of the thyroid. Those are all primary. Or case number 4, which is secondary, could be the pituitary. Okay? So in this patient that's got this overactive nodule, they prescribed a thyrostatic drug. The thyrostatic drug is known as carbimazole, C-A-R-B-I-M-A-Z-O-L-E, carbimazole. And in this particular patient, in about 6 months, or less than 5 months, almost 6. So international date stamp there. So it's the bottom image is the 29th of December of 2008. So they go day, month, year, which actually makes more sense to me, but that's okay. So you can see the amount of weight gain in this individual. The little neck charm that he's wearing is nice because it gives you a relative frame of reference of size. It's like the scale bar. So now this patient is sort of homeostatic thyroid activity and is gaining weight the way that he's supposed to do so. So, hyperthyroidism. So as a subset of hyperthyroidism, let's talk about Graves' disease. Graves' disease. You got autoantibodies to thyroid stimulating hormone receptor. So it mimics what thyroid stimulating hormone does that comes from the anterior pituitary. And again, type 2 hypersensitivity. These patients, in addition to having hyperthyroidism, they usually have enlargement, hypertrophy, and hyperplasia, or an increase in cell number of the thyroid gland. The thyroid itself gets a little bit bigger. Under palpation, in the Graves' disease patient, that thyroid would be palpable, it would be enlarged, or they would be able to determine that. They would have this rare dermopathy, which is shown in this image. And so it's only about 4 to 5% of these patients have this type of condition, of this pretibial dermology or derm pathology that's taking place, where they get kind of a rash on the tibial crest. But they lose a tremendous amount of weight, just like what you saw in that previous patient, which had the nodule. This patient has the Graves' disease, primary hyperthyroidism. But most interestingly in these patients, the clinical manifestation that we see is this eye disease. This eye disease that's called an exophthalmos, and it's this bulging eye condition in hyperthyroid patients that's shown in this particular picture. Usually these are patients that have been wrestling with hyperthyroidism unmanaged for a long period of time. And so this picture, or this diagram on the left, is to remind us, this is the same image that I showed you in our hypersensitivity lecture, where we've got antibodies that are anti-TSH receptor. So they bind to the TSH receptor. Remember, TSH is going to come down from the anterior pituitary and bind in the thyroid and activate the thyroid epithelial cell to manufacture T3 or T4. And here you've got antibodies that bind to the receptor and they turn the receptor on. Okay? So that's what's happening with this particular type 2 hypersensitivity that leads to hyperthyroidism. Well, we could have a situation where the thyroid is underactive. So let's just guess for a minute. If it's overactive, we get severe weight loss, okay? Let's see some other things with hyperthyroidism. Weight loss, high metabolism, accelerated heart rate, difficulty sleeping, okay? Increased respirations. Basically, it's as if they're exercising all the time. They're kind of amped up. Hypothyroidism, what do you think the clinical manifestations are going to look like in that patient? Lethargic, weight gain, a lack of energy, that's lethargy, right? Tired all the time, kind of having mental sluggishness, meaning it's hard to process things, they're not really alert. Okay, so that's the opposite of our hyperthyroidism. Whoops, sorry. And that's this picture. So here's an untreated individual in A, and then that same individual treated in panel B. So in hypothyroidism, our primary ways that this manifests itself are autoantibodies to the thyroid itself. Okay, so now the thyroid is being targeted, not the TSH receptor, but the thyroid tissue is being destroyed. There could be an infection that takes place in the thyroid, usually a bacterial infection. leading to thyroiditis, or thyroiditis, rather, thyroiditis. An endemic goiter. An endemic goiter that's different than what we have where the tissue is overactive. Now the tissue is underactive. And you see this endemic goiter situation happen where there's an underactive thyroid, typically in third world countries where you don't have enough iodine in the diet. Okay? So if you're dietary malnutrition and you're not getting enough iodine, so where do you get iodine from? We get it a lot from seafood, tuna, cod. You'll get it from seaweed, eggs, milk. All of those products will have iodine in it. So those tend to be desirable foods. And so in poor environments, it's harder to get access to some of these nicer nutritional food supplies. And so iodine might be compromised in those particular patients. And so in our country, just one story, we've had a series of challenges in our country. You guys lived through the Great Recession, which was, minuscule in comparison to the Great Depression. Not that I lived through the Great Depression, but my grandfather did. And I remember talking with him an awful lot about what his life was like during the Great Depression. And then, of course, we lived through the Great Recession, and there are very different stories. Well, as kind of an outcome of that, there was a lot of poverty in the U.S. And we started seeing some issues associated with endemic goiters here in the U.S., okay, earlier in the 1900s. And so the nation's food supply made a decision to add in iodine as a supplement so that there wouldn't be an American citizen that was without iodine. So what target did they focus on? Salt, right. Pretty smart, right? Wasn't like hot sauce or pepper. Everybody hates that. People love salt. So if you go to the grocery store and you see iodized salt, or you see salt that's just plain salt that says not a dietary source of iodine, that's where this is coming from. Okay, so we've started supplementing our salt years ago, and now it's not as big of a deal. And so you have the option to buy non-iodized salt, or you can get iodized salt.
Is that Hashimoto disease, like autoimmune antithyroid antibodies?
Yes, we're going to talk about Hashimoto's. We're not going to
That's T cell, right?
Yeah, so that's a T cell involvement. So this is a type 2 hypersensitivity that we're going from Graves' disease, right, for hyperthyroidism. And then now we're talking about hypothyroidism, where we'll talk about Hashimoto's here next, but we're not quite there. It's like one slide. Yeah, it's the next slide. Okay. All right, let's talk about secondary. Well, so there could be a congenital defect of primary. So primaries are autoantibodies, bacterial infection, an endemic goiter, meaning you don't have enough salt in your diet, or congenital. There could be a developmental disorder where the thyroid doesn't completely form. Secondary manifestations, these are like side effects. Well, if you have a patient that is hyperthyroid and you destroy part of the thyroid with anti-thyroid drugs like carbimazole, then you render the thyroid underactive. Or if you remove the thyroid because you're worried about it being cancerous and spreading, now the patient is hypothyroid. And so those patients have to be supplemented for the rest of their life with thyroxine. Okay? It's a pretty inexpensive medication because it's generically available now. So usually, it's like $5 to $8 for a month's supply or something like that. It's not a big deal. But they have to take a dose of thyroxine every single day. Okay? Secondary. All right, so let's talk about Hashimoto's disease, because apparently you can't wait. This is a type 4 hypersensitivity. This was actually the most common cause of hypothyroidism. And hypothyroidism tends to be the more common of the two scenarios, whether it's hyper or hypo. Usually it's hypo versus hyper. If it's hypo, oftentimes it's because of this. In Hashimoto's disease, this is Hashimoto Akura, who passed away in 1934, Japanese physician. And this is a type of thyroid disease that was characterized by him at Kashura University, which is where the medical school was. And he published his findings in 1912. Okay, so we're like 107 years later from when Hashimoto described it. But this is a type 4 hypersensitivity, and you know that because of why?
T-cell involved.
We've got our T cells that are involved here. And so you can see from this diagram, we've got the thyroid epithelium at the top. We've got T cell sensitization to some type of thyroid antigen. So you're self-reactive to your own antigens. And you've got CD4 positive helper T cells that are triggered. Those on the left side of the slide will activate macrophages and stimulate an inflammatory mediated activity. But wait, there's more, right? So your helper T cells go down this middle pathway, and they activate these cytotoxic T lymphocytes, CD8 positive cells, that go through cytolysis and actually target and kill the thyroid epithelium. You also have the ability for autoantibodies to be made. And remember, if you think back to Unit 1, when we characterized the different types of hypersensitivities, we said that 1, 2, and 3 were antibody-mediated only, and 4 had T-cell involvement. However, oftentimes you might get autoantibodies in addition to the T-cell involvement. Here's an example of that, Hashimoto's disease. So yes, on the right side, your right side of the slide over here, you've got plasma cells that are being activated. They're manufacturing anti-thyroid antibodies. And so you're destroying the thyroid epithelium via 3 different individual pathways. Inflammation, right? And we've got cytolysis in the middle. And then on your far right, we've got antibody-mediated activity, Hashimoto's disease. And this is just to highlight this helper T cell. Like we always talk about the helper T cell being this linchpin or this key cell that has the ability to do all these different things. Well, we're looking at all these different things here as being a problem because now the T cell is doing 3 negative things. But just pretend for a moment it's not thyroid epithelium. Pretend for a moment it's a foreign invader, right? It's not supposed to be your own tissue that you're harboring an immune response against. But if you had a foreign invader and you took your helper T cells and you said, let's make sure we attack this thing, look at all the different branches that the T cell, the helper T cell, is able to accomplish. Does that make sense? So Hashimoto's disease, I think, almost best exemplifies how the immune system is supposed to work in a situation where it's attacking your own tissue, which is not supposed to happen. But if you substituted out thyroid epithelium for something that was foreign that you didn't want, a bacterium or a virus, this is a very effective 3-pronged approach to try to defend us. Does that make sense? So I like to use this slide to remind you of this concept of this linchpin cell, or this key cell that has such important activities. So we do have some situations that are juvenile. We've got hypothyroidism that happens in juvenile patients that are congenital, where it doesn't form correctly or it's not fully matured. And another term for this is cretinism. So congenital hypothyroidism in these patients is also known as cretinism. And you can see this list of clinical problems, which should make sense to you. We have patients that become very cold. They're cold intolerant, meaning that they're not really manufacturing a lot of their own body heat, okay, because metabolism is low. And they're listless, or they're not full of activity. They gain a lot of weight. They have a lot of tissue edema because the blood pressure is not appropriate. So they're not bringing a lot of fluid back into the venous side of the circulation. Unfortunately, they usually wrestle with constipation. It's because metabolism is so slow, and so bowel activity or intestinal motility is compromised. It's actually very reduced. And then they get a lot of pericardial effusions, which can be problematic if it's left untreated. Because they have a lot of fluid that kind of is leaking out into the tissues, that happens around the heart as well. And if there's a lot of water on the heart, we can get into a situation we know as cardiac tamponade, where that water puts pressure on the heart, and the heart has to beat against a higher pressure, and that can lead to premature heart failure. So you can see this patient example in this young girl. This is a 10-year-old, okay, 10-year-old untreated, kind of in the middle, or the left picture. And pre-treatment, she's got poor growth. She is relatively obese for her age group, immature body proportions. She hadn't lost a single deciduous tooth at the age of 10. So she is behind developmentally. That makes sense? And she was treated, and then after she was treated, where we get the thyroid more active, or you treat with thyroxine or a supplement that's going to be throughout the body, you actually get severe catch-up, which is what's shown on the right image. And so this is treatment that is just 10 months later in this young girl. Okay, so now she's just under 11. She's lost 6 teeth in those 10 months. She had a striking amount of catch-up in growth, and you can tell the growth by the relative length of her legs, okay? Bone age was 5 years pre-treatment. So she was behaving as if she was a 5-year-old, which makes sense. She hadn't lost a tooth yet. Usually kids start losing teeth around 5 years of age, okay? Somewhere between 4 and 5 years of age. So she was 5 years of bone age in the left image, okay? And on the right image, in 10 months, she caught up chronologically to an age of 10. So she's 10 years, 10 months, but her bone health is actually at 10 years of age. In this particular patient, from a diagnostic standpoint, they diagnosed her by measuring and confirming the diagnosis by measuring TSH levels. So why do you think TSH levels are helpful in understanding this particular disease? There could be other things too that they're measuring, but why is it so important that TSH levels are measured to be able to determine what's happening with respect to the thyroid? I didn't tell you if it was high or low, so you got to tell me kind of, in this patient, what would you expect TSH levels would be, high or low? Normal? Low?
I'm trying to figure out if it's listed pituitary or not.
Think it through. So, the pituitary controls the thyroid. Thyroid makes thyroid hormone, right? There's not enough thyroid hormone being made by the thyroid gland. What is the pituitary gland going to do? Make more thyroid stimulating hormone to say, hey, thyroid, wake up. So the anterior pituitary, you would measure TSH levels and they should be abnormally elevated. And then you're going to simultaneously measure thyroid hormone and it should be abnormally low. Does that make sense? So abnormally high TSH levels coming out of the pituitary in concert with very low circulating thyroid hormone tells you the thyroid gland is not responding. You with me? Anterior pituitary is sending the signal, it's not getting a response. It's like, sends the text message, no reply. So sends another text message, no reply. Right? Then it's like emoji, okay? And then finally, no, can't imagine. It dials the phone number. Hello? How come you're not texting me back? Right? So the thyroid is not responsive. And you know it's not responsive because there's low thyroid hormone. So do you see how you really have to understand these axes of what's going on? Whereas if you looked at this patient, you wouldn't know if you just looked at one side of the equation like TSH only without looking at thyroid. You need to know the whole picture to be able to put it together. Questions over the thyroid? All right, our last little section is on pancreas. Okay, endocrine. There's a lot of other organs. We're not going to have enough time, and I'm not going to carve out more time and send more information with you to study through the weekend. So we're just going to end it with pancreas. We'll get through the pancreas, and that's where we'll hit the pause button. There are other tissues, obviously, that are described in your chapters. But again, the whole concept of this class, I think at this point, getting up for exam 2, you guys hopefully can have an appreciation for the strategy. I expose you to a broad amount of material in the readings, right? You get open book, open note, pre-quizzes and post-quizzes, where you have at your fingertips all sorts of information that you can go find. And then we try to pare this down to a couple of key examples that drive home the concepts that we're learning about, bless you. And the idea is, in the future, if there's another endocrine organ that you come across that you want to look at, okay, like the adrenal medulla, okay, or you want to look at reproductive organs, you could have situations where things are upregulated or they're downregulated. It's kind of the same principles that will apply to the next endocrine organ. You guys with me? Okay. That's my explanation as to why we're only going to look at pancreas moving forward, and that's it. But there's a lot of material here. So let's look at the pancreas, and let's talk about diabetes mellitus. So diabetes mellitus, uniquely different than diabetes insipidus. What was diabetes insipidus? We talked about it in the last lecture, right? Remember how I told you, I want you to have the ability to remember, oh yeah, we talked about that one back there. That was a problem with what structure? Posterior pituitary, very good. And it manufactures what? ADH, antidiuretic hormone, also known as vasopressin or vasopressin, very good, okay? And what does it do? What does ADH do?
You have to take some water.
It helps to encourage the conservation of water at the level of the kidneys, right? So if you have diabetes insipidus, it translates as siphoning without taste. You're losing a lot of water. Do you remember that? And you're losing a lot of water, so you get hypernatremia, you get high sodium levels in the blood. This disease has nothing to do with the brain, okay? We're at the pancreas, diabetes mellitus. Very similar sounding words, but they mean very different things. They're two completely different organs. Diabetes mellitus is siphoning sweet like honey. Mellitus is sweet like honey. It could be used as a term of endearment. Mellitus. You can name your daughter Mellitus if you'd like. I've already named all 4 of mine, so my wife didn't like Mellitus. I thought it was kind of a cool Latin name, but she didn't go for it. So, I mean, come on, you call your loved ones honey or sweetie, right? You can call them Mellitus. No? Bad idea? No, that's a curse, huh? Okay. So diabetes mellitus, but now you won't forget the term, right? You're like Mellitus. That's what Keller wanted to name his daughter. God bless them. Okay, so diabetes mellitus, in this situation, there's a couple different types of diabetes mellitus. But if we have the inability to produce insulin, then we say that's type 1. An inability to produce insulin, or functional insulin. And type 1 used to be called childhood diabetes, but that's a non-favorable term anymore. In older literature, you'll probably see it. Okay? The reason we don't call it childhood diabetes anymore is because we are diagnosing type 1 diabetics in their 20s and even 30s. And they're definitely not children anymore. Okay? If it's type 2, then you've got an inability to respond to the insulin. You might make insulin, but you're not responding anymore. You become like hypersensitive or hyposensitive, undersensitized to the insulin that you make. Or the insulin that you make might actually have mutated over time. You still make it, but it's not biologically functional. So type 2 diabetes, where you're not responsive to the insulin, typically does have following it some sort of beta islet cell dysfunction. So insulin, if you recall, insulin is manufactured by the beta cells, the beta islet cells of the pancreas, right? Because the pancreas has an endocrine function, which is what we're talking about. It also has an exocrine function for digestive enzymes. So it has dual purpose. The pancreas is a very important organ. And then our third category, so we have type 1, type 2. Type 2 used to be called adult diabetes, okay? it has a high or a close association with obesity, but it is not that all type 2 diabetics are obese or that obese individuals always become type 2 diabetics. But there is a correlation that exists between diabetes and type 2 diabetes and obesity. But we don't really refer to it as obesity diabetics or adult-induced diabetes. We just refer to it as type 2, okay? Then the third one is gestational. In women, during pregnancy, have about a 3 to 10% chance, it's about a 3 to 10% chance of pregnant women developing gestational diabetes. Why is that? What's going on? Well, oftentimes with gestational diabetes, what's happening is the infant or the embryo is kind of, utilizing more and more of the energy. And so the pregnancy in the females, the woman becomes a little undersensitized to her own insulin. So the sugar that's in the bloodstream, insulin takes the sugar out of the bloodstream and puts it into the cell. So in certain women that develop gestational diabetes, that sugar never leaves her blood and goes into the cell. That sugar stays in the bloodstream and goes over to the embryo, and then the embryo has access to it. So one of the thought processes is, could have this been an adaptation during human development over time, where in phases of civilization when starvation was happening, the species still survived, where the mother basically compromised her ability to bring sugar into the cell and allowed it to be available for the developing baby. Does that make sense? So 3 to 10% of the population develops pregnancy-induced diabetes. Now, the challenge, one of the big challenges for the infant is usually you have higher than normal birth weights because the infant's getting a tremendous amount of sugar. Okay, question?
Yeah. Post-pregnancy, does it kind of revert back to the original state?
It can, yes. Oftentimes it does, but there's lifestyle adaptations like watching what you're eating, exercising, same kind of things that we prescribe for type 2 diabetics. So basically, gestational diabetes, that woman in that pregnant period of time is kind of having symptoms like a type 2 diabetic. And so we try to manage it very similarly. So how's diabetes diagnosed? Oh, so before we go there, this diagram, I don't want to make light of this diagram. So insulin has activity on fat, muscle, as well as liver. So it's a molecule that has a lot of ubiquitous activities. That's a really expensive word you should try to use this weekend, right? Meaning that it has many different activities that it initiates. So in fat, it will increase sugar uptake. It'll increase the production of new fat, and it lowers the breakdown of fat. You're going into a storage mode. In muscle, striated muscle, like skeletal muscle, you increase sugar uptake, you increase the storing of sugar or glycogen, and then you increase the development of new muscle or protein synthesis because you have energy. And if you look at the liver, you lower the formation of new glucose because the liver is the organ that's responsible for manufacturing new glucose. So your blood sugar levels actually stay pretty homeostatic. So that word gluconeogenesis, you can see that's glucose, new beginnings. That's what it translates to if you break it down. So the liver now doesn't have to work as hard to make new sugar, so gluconeogenesis drops, and you start storing the excess sugar in the format of glycogen, right? That poly chain of sugar. And then you actually encourage lipogenesis. Even in the liver, you'll store energy in the liver. Okay, so how do we diagnose diabetes? Doesn't matter what type 1, type 2, or gestational. Normal sugar levels are 70 to 120 milligrams per deciliter. In diabetes mellitus, that's DM, you either have a situation of over 200 milligrams per deciliter on a random draw, and you have symptoms, you're symptomatic. Or It could be a fasting, you haven't had a meal in maybe like an 8 to 10 hour period of time, but your sugar levels are at 126 or higher. Or thirdly, which is a little bit more common these days, is you do an oral glucose tolerance test. So what happens is you give the patient an oral dose of sugar, and then you measure, take blood draws, and you measure how the sugar levels are spiking. If we look at what happens in our day, and this is not a nutrition class, but I want to walk through a couple of things that some of you might find fascinating or interesting, okay? So we get, in our day, we have 3 major spikes of sugar. And they typically follow after each meal, as you can see here. So you have breakfast in the morning, right? You break the fast, you haven't eaten since dinner. So you have this huge flood of sugar in your bloodstream, and it's followed by a peak of insulin, saying, all right, great, sugar, let's bring it into the cell. Then around noon, you do this all over again. And between breakfast and noon, you can see that those levels drop, those sugar levels drop. And then you do it again around dinner time. So you do this for a lifetime, but let's say that you do this for a lifetime and the consumption of foods at those 3 periods of time are dramatic. And the quantity of sugar is high. Well, so the spikes get bigger, so the peaks and the valleys kind of do this for 40, 50, 60, 70 years, okay? And past 40, on average, will retain maybe 5 pounds a year, on average. So at the age of 50, you could have an individual that's 50 pounds overweight. Eating habits are 3 huge meals a day, high sugar, and you're asking this insulin to do the same thing for 50 years. You see kind of a formula that, wow, this is kind of, could be a problem. So what a lot of like diets have started to do is say, okay, let's eat smaller meals. Let's regulate the amount of sugar that's in our starches or carbs that are in our diet, and let's spread out the meals. Instead of 3 meals a day, let's actually consume calories 5 times a day, but make the meals a little smaller. Okay? So that's where you're getting a lot of these kinds of different types of diet strategies, is try to prevent a lot of this fluctuation. Because one of the big theories in medicine that we have with problems associated with type 2 diabetes, which is an epidemic in our country, is our habits, like our lifestyle habits. And of course, I'm talking about patients that aren't eating real healthy, and they're not exercising whatsoever, okay? And then you put this sort of strategy for 50, 60 years on top of that, it's kind of a recipe for disaster. Okay, so let's look at type 1 diabetes pathogenesis, and then we'll look at type 2, and we'll talk about some of the manifestations. So type 1 diabetes is an autoimmune disorder. You've got hypersensitivity reaction. It's a type what? The answer's on the screen. If you don't remember. We talked about this back in hypersensitivity. Is it type 4? Why is it type 4? Because you've got CD4 and CD8 positive T cell involvement. We also have B cells that are involved. In this situation, you've got 80 to 90% of the beta islet cells that are destroyed, and the patient is in a hyperglycemic situation. So in this diagram, under a healthy condition, the pancreas produces insulin, these little green spheres. It binds up the glucose, and then it moves the glucose into the cells. In a diabetic situation, you've got the immune system destroying the beta cells, the beta islet cells in the pancreas, and you get a lack of insulin production. So the sugar stays in the bloodstream and it doesn't actually move into the cells. Pretty straightforward, right? So symptoms from these patients. These patients have symptoms, if you remember the 3 Ps. So we've got polydipsia, excessive thirst. We've got polyphagia, excessive eating. And then we've got polyuria, large amounts of urine production. So why? Why do each of these occur? Well, the polydipsia, the excessive thirst, the high sugar inside of the blood causes an increase in osmolarity of the blood. And the hypothalamus detects that and says, I'm thirsty because my osmolarity in my blood is high. That's polydipsia. Polyphagia, excessive eating, you have the hunger centers that actually are triggered in the hypothalamus because you've got plenty of energy or sugar, but it's not making it into the cell. It's sitting in the bloodstream. So you're still hungry because that sugar has never made it into the cell. So you have polyphagia. Now, why in a type 2 situation do we have a lot of weight gain? Well, there you go. They think they're still hungry because the insulin's not bringing the sugar into the cell, and so they continue to eat. And then polyuria, in this situation with diabetes mellitus type 1, large production of urine happens because you get saturation of proteins in the kidney. And so now you've got a lot of sugar that's making it into the urine. And when the sugar crosses into the urine and you excrete it, water tends to follow solutes, and so you lose a lot of water with the urine. And then that's in the old days, before they were doing blood draws and looking at sugar levels, they were actually measuring or evaluating how sweet the urine would be, and that's where it got its name. Right? So this is siphoning off sweet like honey. Patients that are unmanaged diabetics have urine that has a sweet smell to it, and that's how it was being diagnosed. That's why the Latin is basically a sweet smelling urine, or siphoned off of sweet urine. These patients lose a lot of weight. They're ketoacidotic, so they're looking for other forms of energy because they don't have glucose in their cell. And so they usually resort to protein breakdown. And so ketones are formed from the breakdown of fatty acids after you've deaminated an amino acid. And of course, kind of no-brainer, we gotta say it, they're hyperglycemic, meaning they have too much sugar in the blood floating around. And that is problematic, and we'll explain why here after we talk about type 2 diabetes. So in type 2 diabetes, it's different, much different, and it's actually a little bit more complicated, and it's far more prevalent. So in type 2 diabetes, we've got the normal pancreas that you saw before, making the little green globs of insulin, binds up the blue balls, which are the glucose, and then transports it inside of the cell. Now the cell has the sugar inside to be able to do metabolic processes. In a type 2 diabetic, there is less insulin that's being produced, or it could be that in that particular patient, they are less responsive to the insulin. So either way, if it's less insulin that's being made, or you have a situation where they're less responsive to the insulin, you've got less sugar that's going into the cell. It's the same end result, whether they're making slightly less insulin or they become unresponsive to the insulin that they manufacture. So they become what we call insulin resistant in type 2 diabetes. Now, there are a number of different genetic defects that the field is trying to uncover, looking at like the insulin receptor and or the insulin signaling pathway. So maybe it's not just insulin, maybe it has to do with the insulin receptor on the cells where it's supposed to bind. Or maybe it doesn't bind as well and trigger internal cellular signaling, so that would be the signaling pathway. These are still questions that remain yet to be determined. Symptoms with type 2 diabetes. often, as I mentioned before, they're overweight, even obese. These patients wrestle with dyslipidemia. That's an abnormal amount of lipid in the bloodstream. They're hyperinsulinemic, meaning a lot of times they have too much insulin being produced because the patient's cells are less responsive to it. So it's kind of like the TSH situation with the thyroid. If you're not responding, you make more of the insulin to try to get the same response. They a lot of times are hypertensive because they have vascular disease, and we'll talk about that here in a second. They have a tremendous amount of fatigue because same problem as we have with type 1 diabetics. You got plenty of energy, but it's not in the right spot. All of the energy is in the blood, and it's not being absorbed into the cell. And they're at risk of recurrent infections. And you see a diabetic foot ulcer on this bottom panel, and I'll unpack that here a little bit more. I mean, a lot of what I've been spending much of my career on is treating these kinds of wounds, or I should say developing technologies to treat those kinds of wounds. Like I like coming with the ideas. I don't want to touch those, but I'll come up with the ideas so that you who touch them can go fix them. Okay, how's that sound? And then they deal with what's called parathesis. Parathesis is a term that's like pre-paralysis. So parathesis is that pinprick feeling, like when your foot goes to sleep, that numb and tingling feeling, which is really annoying. So patients that have these kinds of ulcers on the bottom of the feet, they've had parathesis probably for years. That's never subsided. You know, like you cross your legs, you sit kind of an awkward way, and you're like, oh, my foot's asleep. You're kind of like doing all, we've had other things to do. I'll go this way. And then, oh, it's so much better. Imagine that nonstop. Hard to fall asleep, super annoying. That's parathesis, that pinprick feeling. Why do they have that pinprick feeling? It's because the nerves are dying. That's the first signal that a nerve is dying. It's getting your attention when your leg falls asleep, like move your leg, you're cutting off blood flow to the nerve, and now it's starting to give you feedback that it's starving for oxygen. So that's what that signal is the early phases of nerve damage. So parathesis continues where they have nerve trauma and they don't feel the distal part of their limbs anymore, and then they kick a bed foot or the side of the dresser, split their toe, they step on a carpet tack, their foot's bleeding, they didn't even know it, and they don't have the best hygiene maybe because they can't reach their feet. They're obese and they can't quite reach their feet, so they're not cleaning very well, and it gets infected, and it's this vicious cycle. Okay, so we'll talk about that here in a second. So that's type 1 and type 2 diabetes mellitus. Type 1 and type 2 diabetes mellitus. Gestational diabetes usually doesn't last very long beyond pregnancy, and so these patients, while they're very much similar to type 2 diabetics, they don't end up progressing clinically as long as they're making adjustments post-pregnancy or postpartum. Okay, this is where we switch to merging the two. Okay, so the next few slides, as we finish out today's lecture, are about diabetes mellitus in general, 1 or 2, unmanaged. So what's going on with these patients? Why is having high sugar in the blood a problem? I'm surprised nobody asked that question yet. Like, other than not getting energy, like who flipping cares if you're peeing out a bunch of sugar? Why is it a problem? You guys with me? So I'm going to tell you why it's a problem. Well, we've got what we call advanced glycosylated end products. So these glycosylated end products means that these are sugar-covered proteins. You got a lot of sugar in the blood, it's going to bind to things like collagen and it's going to cross-link it. And then you're going to get sticky collagen that fats will adhere to, and now you get fat accumulation in the blood vessel. And that creates a lesion. That's where your vascular disease happens. Okay? You could have plasma proteins. You could have complement, for example. And you get glycosylated because it's sugar-coated now. And then it loses its activity. We could have situations like protein kinase C activation. So protein kinase C activation takes place in diabetics, where you've got pro-angiogenic molecules like VEGF that we've learned about, but it shows up in places that it's not supposed to show up, like in the retina. And now you get this diabetic retinopathy where you get an immense amount of vascularization happening in the back of the eye, and the patient can go blind. And that's where we get diabetic blindness from. These are unmanaged patients that are like, to heck with it. I'm gonna eat what I want, I'm not gonna exercise, I don't like exercising. You know, they can't tell me what to do. Okay, unfortunately, let's keep going, right? So let's talk a little bit about chemistry. Well, this is the polyol system. So the polyol system that's important for you to recognize is we've got glucose goes through a reduction reaction to an intermediate known as sorbitol. And then sorbitol is converted to fructose from sorbitol dehydrogenase. And fructose itself has the problem of increasing osmolarity in the bloodstream. And now all of a sudden you get all this extra water accumulation because of the lasting fructose that's circulating around. And that increase in osmolarity causes retention of water that can cause cellular trauma or cellular damage. And if you cause cellular damage in the blood vessels, now you create lesions on the endothelial cell where you've got vascular damage. So diabetes mellitus, unmanaged. These slides are all unmanaged diabetes mellitus patients. We've got vascular disease, we've got diabetic neuropathy, and we've got diabetic nephropathy. So in diabetic or vascular disease, which is characterized in diabetic neuropathy, these nerves are starving from a drop in blood flow because you've got these vascular lesions that are restricting blood flow to the distal extremities. And that's why the feet and the toes are at high risk. And the other problem associated with high sugar levels is nerves don't like high sugar environments. It's almost a poison to them. And so if you have a high sugar concentration around any nerve for a long period of time, it's not going to like that. It's going to respond in a negative way. The diabetic nephropathy, not neuropathy, that's nerves. Nephropathy is referring to the kidney. Well, the kidney is well vascularized by a network of capillaries. So it's a vascular disease of the capillaries of the kidney. And now the kidney function is compromised. Right? Because these blood vessels are everywhere. So what does this look like? Well, this is a image of endothelial cells, and this is in the renal cortex. And we've got a thickening of the basement membrane in this particular patient population. This thickening of the basement membrane is characterized by the over-exaggerated pink stain, which is the basement membrane. Okay, these are in the renal tubules. And so what you're looking at here is, here's a basement membrane that's quote-unquote normal. See how thin that is? Here's one that is pretty normal. Here's one that's pretty normal. Look how thick, here's a normal one. Look how thick these guys are. So if you have basement membrane that thickens, what happens to diffusion? Is it improved? No, it's compromised. Right? So this microvascular disease, this is at the kidney level, but the microvascular disease, because of these advanced glycosylated end products, the sugar coating that happens, it's preventing blood vessels everywhere from their normal functionality. We see blood vessels showing up in the retina where it's not supposed to be, leading to blindness. We've got compromised perfusion of the kidney, so it leads to renal failure. You've got compromised blood flow to neurons or nerves, that are peripheral nerves in the distal extremities. So now you have these neuropathies, or this parathesis terminology that we've been talking about. That's at the microvascular level. Then you've got macrovascular effects, larger blood vessels. Well, those glycosylated end products happen everywhere, so the larger vessels, you can start developing coronary artery disease. It's not a huge vessel, but it's larger than capillaries. And you get a lot of accumulation of high levels of low-density lipoprotein. Low-density lipoprotein. And what does that do? Let's talk about LDL and HDL briefly. We'll talk more about these two in the cardiovascular section. The HDL is considered the good cholesterol. You guys remember this one? And this one's the bad. Why is that? Why is LDL elevated a bad thing?
It brings fats to the tissues that are not in the liver, and HDL brings fats to the liver from the tissue.
That's exactly correct. So if you're a developing child and you have a lot of tissues that are growing and developing, having LDL levels that are higher or elevated, let's use the word elevated because it's confusing if you use high LDL for LDL and you use high for high LDL. So elevated LDL, meaning you take fat from the liver and put it in the bloodstream so that it's available to make new cellular membranes. Not a problem. HDL does the opposite, is it takes fat out of the blood and it stores it in the liver. So now your lipidemia levels in the bloodstream are low. So that's why you want lower HDL levels, and you can have higher amounts of the good cholesterol. If you have macrovascular disease, you're at risk of stroke and infarction of the heart. All because of this sugar that's floating around in the body, which is a big problem. So we talked about neuropathy, nerve damage. We talked about the polyol pathway, sugar in the form of glucose being converted to fructose, increasing osmolarity. Now we've got the peripheral nervous system in the lower extremities at highest risk. Doesn't matter if this is type 1 or type 2 diabetes, if they're both unmanaged, they have the same kind of clinical sequelae. And poor perfusion to the distal extremities leads to these foot ulcers, and in extreme circumstances, that foot ulcer can become infected. And if it becomes infected, it's hard to control. It's a chronic diabetic foot ulcer that won't close. And that infection usually spreads. Well, where does it spread? Well, it's going to spread first to the toes, and then the solution might be, well, let's amputate. We'll amputate, cut off the infection. Well, a lot of times it doesn't stop there. It moves more proximal, and so they'll have to amputate at the ankle. Then they might have to amputate below the knee. And in the worst case scenario, they got to go above the knee. And that is the most debilitating amputation that can happen in the lower extremity. And the reason is you've lost two major joints. The ankle and the knee are major joints for prosthetics. So when you're above the knee, it's very complicated to fit a functional prosthetic because that joint is so critical for your mobility. And so all the patient care with these diabetic foot ulcers is trying to eliminate amputations and trying to prevent significant amputations moving more proximal. So what's going on? Well, this high glucose content. So glucose actually impedes oxygen release from a red blood cell. So here's another point against us, right? You have high sugar in the blood. Now, any sort of oxygen transport in and off of the hemoglobin molecule is impeded or not blocked, but it doesn't happen as smoothly because of the sugar content. We've got a compromised vasculature like we've talked about, and we've got that high sugar content where we've got that polyol pathway increasing osmolarity because of the resident fructose that's in the area. Okay, so now that you've scared the crap out of us, Keller, how do we treat these patients? All right? So you guys have seen in like the wound healing lecture, all the different things that we've been doing strategically over the years to treat these kinds of wounds. So we have some really great tools to treat these wounds, but there's things that we can do to prevent them from happening. Okay, and this is where a lot of the education happens. But let me start this. For type 1 diabetics, a lot of times insulin injection is very successful at managing type 1 diabetes. They have to monitor their diabetes, their sugar levels, and they have to decide when they deliver their own insulin. And now we have synthetic insulin. Okay, you don't just have to do horse insulin, you can inject a recombinant synthetic. But why is it not a pill? Why can't we just take a pill? What's that? It breaks down too quickly. The insulin's kind of a weak protein, so it's not very resilient. And this is a pretty harsh environment, okay? So that's why it's not yet a pill. That could happen in your lifetime. Could we develop better coatings for a pill? Maybe. So that would be a cool area of research that I would love to see some of you, email me or whatever, holograph me or whatever we do in the future. Send me some sort of telepathy message. I would do that. That you're onto this new pill for diabetes. Okay, there's a tremendous number of oral or injectables for type 2. Diet modification. A lot of times we'll push patients to watch the amount of carbohydrates they consume. Okay, and portion control, calorie control. And then last but not least, it's like, the doctor's always saying exercise, right? So your exercise science majors, you're gonna like this one, okay? How many of you are exercise science majors? Okay, all right, so for the two of you that are in the room, here you go. If you look at this picture on the left, there are alternative pathways other than insulin to get sugar into a cell. And GLUT4 is a very effective sugar transport molecule for glucose. And what's interestingly found and discovered in exercise science, and this was put in here for all of you exercise science people, is we treat our patients not with just lifestyle choices on their diet, but also their exercise. You can exercise more regularly in between those meals. You can kind of keep that calorie burden in check. But exercise upregulates the insertion of GLUT4 receptors into the membrane of the muscle. And so GLUT4 is an alternative way to transport glucose into the cell that is not dependent on insulin. And that's why exercise, regular exercise, just getting your patients to walk around the block like 2 or 3 times a day can really assist in upregulating the amount of GLUT4 receptors that are inserted into the plasma membrane of their skeletal muscle. That can help control the amount of sugar that's in the blood through a non-insulin dependent pathway. Kind of cool, okay? So that to me, that's the additional piece you should try to figure out a way to explain to your patients other than you should exercise more. I know they're always telling me that, right? Here's why. This is why it actually works. Okay, questions? That's all I got for you. Have a great weekend studying. I know that's like an oxymoron, and I'll see you guys on Monday.